This is a recording from our 2023 Core Anesthesia Conference. We want to say thank you to all of the speakers who took the time to come and present, and also the sponsors who made the event possible for all of the residents. If you want to learn more about the speakers or our sponsors, please check out the show notes, and please enjoy this pre-recorded session.
So now I want to introduce our next speaker. Again, we're really excited to have Rebecca Collier on with us. She is somebody that both Tanner and I were introduced to in school. She had so much knowledge to pass on to us, so we were super excited that she said yes to come on and talk today. I think anybody who knows her knows that she is a pediatric whiz, so we are very excited to have Rebecca on here. I'm just going to introduce her, and then we'll let her start her session. So Rebecca is a triple alum from Southern Illinois University at Edwardsville. She completed her MS Nurse Anesthesia Specialization in 2003, and in 2013, she completed her DNP and has been a faculty member at SIUE's Nurse Anesthesiology Department for 10 years. Rebecca has provided anesthesia for almost 20 years at HSHS St. John's Hospital in Springfield, Illinois, and she became a NAPA employee in May of 2022. She specializes in neonatal and pediatric anesthesia and has been a member of the high-risk OB team for the past 3 years. Rebecca also enjoys quality improvement and has mentored several students through the DNP project process. She's active on multiple committees and serves in a leadership role at HSHS St. John's. And Rebecca has provided anesthesia on 3 medical mission trips in Yendi. Is it Yendi or Yendi? Maybe she can tell you in a second, a remote village in northern Ghana, Africa, with Mission 318. And I loved talking to her about her stories of doing anesthesia over there. It is incredible. But with that being said, I really want to welcome Rebecca to the stage, and we'll hand it over to you.
Thank you, Cole. Can you hear me okay?
Yes, we can hear you.
Okay, great. You
should be able to share your presentation. I think we give you access to that.
Perfect. All right. Can you see it?
Yes, we can see it.
Okay, great. Well, good afternoon, everybody. I'm honored to be able to speak today, and I hope that you all enjoy the presentation. My goal is for the anesthesia residents to get maybe a little piece of knowledge that they didn't learn in their pediatric rotation, or even gain a lot of knowledge that they can use for their upcoming pediatric rotation. So today I'm going to talk about the down low on putting kids under. Like Cole said, I have been on 3 mission trips to Yendi, Ghana, the last 3 years, actually, 21, 22, and 23. And I've been able to do some pediatric anesthesia over there. So it's definitely been a challenge and very interesting. And I will share a few pictures in my presentation with you all today. The last 2 years, I've been able to take a student from SIUE with me too. So that's been great. So I'm going to start out with a standard disclosure statement. I don't have any financial relationships with any commercial interests related to the content of this activity. Most of what I'll talk to you about today is evidence-based, but some will be anecdotal after 20 years of PEDS experience and teaching students in the classroom and in the OR. I'll also talk a little bit about some off-label use of medications that aren't approved for pediatrics. Really nothing is approved for pediatrics. So if you know anything about developmental pharmacology, you'll know that most of what pediatric anesthesia providers do is off-label. And the 2 drugs in my presentation are bupivacaine and dexmedetomidine. So as far as learner outcomes, we're going to talk a little bit about the factors contributing to SRNA anxiety about pediatric anesthesia. We'll talk about the clinical relevance of growth and development to pediatric anesthesia and we'll review some key aspects of the anesthesia pre-op eval of children. And then I'm just going to talk about some tips for success during induction, maintenance, and emergence that are unique to pediatric anesthesia. And my hope is that you can actually use what we're going to talk about today in clinical. So we have a pediatric rotation at St. John's where I work, and I hear a lot of students say things like, peds is so intimidating, kids scare me, I'm never going to feel comfortable taking care of children, I don't want to take care of tiny humans, the whole gamut of things. I've seen students extremely upset about taking care of kids. So we're just going to talk a little bit about why you feel that way, and that it's normal to feel that way. So if you look at SRNA education, there's 130 accredited programs in the United States for nurse anesthesia, and they graduate a little over 2,400 students annually. And if you look at the NBCRNA data from 2022, there's still master's programs data reported in the last survey. So that's why there's master's and doctoral programs. The total number of cases that the students that graduated with their master's degree, the average student had 873.9 total anesthesia cases before they sat for NCE. The doctoral students had an average of 855 cases. So if we look at that same data and look at the number of pediatric cases that the graduates are getting from the master's program, the mean total for the master's students 2 to 12 years old was 62, under 2 was 20, and then neonates was only 1. And then if you look at the number of cases required, you can see that the graduates are doing pretty good with their 2 to 12-year-olds. They're getting an average of double, and they're getting an average of double the required peds cases under 2. And then the NBCRNA doesn't require any neonates. So if we looked at the doctoral programs, it's about the same. So double the number of cases required for 2 to 12, double under 2, and again, 1 neonate. So if we look at the clinical background of the students that graduate, according to NBCRNA, there were 21 total NICU nurses and 110 total PICU nurses in the entire group of over 2,400 students that sat for NCE. And just of interest, I highlighted that over the past 5-year trend, PICU nurses actually score the best overall on the NCE. Their pass rate percentage is 86.7%. So I thought that was interesting. So if you look at that and you say, what causes SRNA anxiety about pediatric cases, less than 6% of all anesthesia residents have PICU NICU background. So your exposure in nursing in general before anesthesia school is very low. And less than 10% of all your cases that you do while you're in training are children. Another factor to consider besides the NBCRNA data is that, the median age of women that are giving birth in the US right now is 30. And 32.2% of all candidates that sat for NCE were less than 30. So, not that you can't have children before 30, but if the average woman is waiting until 30 and a third of the SRNAs are under 30 in school, then most likely they're not moms. At least the majority of them aren't. And so depending on how close you are to younger siblings or nieces or nephews or cousins, you may not have a whole lot of personal kid exposure while you're in anesthesia school either. So you didn't work with kids, you're not getting the cases in school, and you may or may not have some social exposure to children. So another thing to consider is less than 9% of hospitals do over 90% of the pediatric surgical volume. And of course, these are children's hospitals. But if you look around, there's a lot of anesthesia programs that aren't affiliated with a children's hospital. And I know as a faculty member, it's a real struggle to get pediatric clinical sites. And the children's hospitals can be very difficult to get into. So again, that kind of isolates, the anesthesia residents. Now, another thing to consider about the anxiety surrounding taking care of young kids is that we know that anesthesia complications are low in healthy children. But still, according to some of the quality improvement data, there are still 5.3 pediatric cardiac arrests per 10,000 anesthetics. And the major risk factors include babies less than 6 months, ASA greater than 3, emergent cases, and then if the case is scheduled at night or on the weekends, that was an independent risk. The majority of causative factors for the cardiac arrests were cardiovascular in nature, but the second overall cause of arrests under anesthesia is respiratory. And this includes airway obstruction followed by inability to intubate or ventilate. And this includes both recognized and unrecognized airway obstruction. So that group, especially under 6 months and even under a year, clinicians have even less experience with. So that is another factor that makes students nervous. Also, preceptor anxiety. If you don't work in a children's hospital and you're not getting continuous exposure to young children, to sick children, then you as a clinician aren't being, you're not maintaining your experience with small kids. So you yourself have anxiety about caring for them, which then means it's harder for you to nurture a SRNA taking care of children. I think students have much better rotations when their preceptors feel confident in their skills. And in order to feel confident doing pediatrics, you need to do that on a regular basis. So only 8.8% of all anesthesiologists are board certified in peds. And I had a really hard time finding any data on CRNAs regarding how many are experienced with children. The only data I could find so far was from the US Bureau of Labor, which says only 38% of us actually work in hospitals or outpatient facilities, which surprised me because I didn't realize the majority of CRNAs were working in like office-based anesthesia. So you can see that even anesthesia providers, there's a smaller number of us that do children on a regular basis. And many people who take care of children lack experience with neonates and critically ill children. So what can you do to try to help, overcome the fear or just, start enjoying your pediatric rotation? I find that most of the time students are very nervous when they start. After a few weeks in, they get more comfortable. And then by the time the rotation's over, they actually will say that they enjoyed their rotation. Of course, I'm sure that varies with where you do it, but I think one of the best things you can do is to really be prepared for clinical and then just get it in your mind that you are and you can do very hard things. The most growth comes through doing challenging things. So these are just some pictures from this past January when we went to Yendi. And Dan McDade, he is a CRNA now, but he was an SRNA at the time. He went with my husband and I this year. And Dan didn't have a whole lot of peds experience when we went. And when we got over there, they were in a full-blown typhoid epidemic. And, we don't get typhoid in America because people wash their hands. But Dan took care of some really sick kids while we were there, like critically ill children. And that was really hard for him. He has a daughter of his own. And again, like I said, the kids were super sick. You can see the majority of them were boys. I think we did 8 total kids with typhoid. And, they had exploratory labs. They needed blood, antibiotics. A few of them got some epi during the case. But so I guess the moral of the story is, this was really outside of Dan's comfort zone, but he did great. And I know that with a little bit of prep and the right mentality, you can have a very successful peds rotation too. So we really can't talk about pediatric anesthesia without just like briefly going through child behavior and development. I'm sure most of you haven't even thought about this stuff since your undergrad nursing program. And don't worry, I'm not going to get really in depth with it. But what I want you to recognize is that while we as anesthesia providers we're not primarily responsible for checking development, behavior, and growth because we're not pediatricians. We can utilize some of the information that cognitive and psychosocial development theories give us about how children cope and how they manage stress based on their age and their maturity, which will help them through the perioperative encounter. We want to, above all, do no harm, right? So it's important for you to know that after 6 months of age, between 6 months and 9 months, babies are going to start having separation anxiety, and they're probably going to need pre-medicated. It's important to know that a 4-year-old is, really does believe that Mickey Mouse exists, and you can use that fantasy kind of world that they live in to really make a connection with them before you go back to the OR. It's also important to know that you can't tell a 3-year-old, in 4 hours this, because they don't live in the future, they live in the present. So trying to explain to them that they're going to see their parents in 4 hours or 2 hours or in a little bit, it's not enough for them. And then, of course, the school age kids are very concerned about bodily harm and having pain. And then, adolescents, a lot of times they won't tell us the truth when their parents are around, and you have to spend some time talking to them as you're rolling back to the OR because they don't want to tell you things in front of their parents. So, just briefly, those were just a few things you can use to your advantage as an anesthesia provider. Now, developmental milestones. So we do have an opportunity to do a, fairly quick pre-op assessment, and you can assess development very quickly. Again, developmental milestones, they range. There's a very, you really have to be late in order for there to be a concern for developmental delay. But still, it is our responsibility as healthcare providers to note developmental delay when we see it, because that children who are behind the developmental curve need referral and early intervention and aggressive therapy to get where they need to be. And actually, the little toddler in the picture is my oldest son, and he was quite the ninja when he was that age. It also helps you understand how kids get injuries based on where they are in their development, because once they start walking and climbing, moms just try to prevent them from killing themselves every day. So anyway, so the anesthesia pre-op eval. So healthy kids having minor surgery require very minimal workup, but healthy kids having complex surgery do require a little more investigation. And sick kids having minor surgery require a little bit more of your time. And then, of course, sick kids having complex surgery, they would need a full-blown anesthesia pre-op consult. And the important thing that you focus on is that you need to tailor your pre-op eval surrounding things in their history that might impact your anesthetic plan. And these would be things like difficult airway, congenital heart disease, things like that. So home meds, most meds should be taken. These include ADHD meds, psych meds, meds for depression, high blood pressure, seizure meds, chronic pain meds should be taken morning of surgery, GI meds like Pepcid, and then, of course, asthma medications we would want them to take. You'd want to hold anticoagulants, ACE inhibitors, the herbals that cause increased bleeding times, and then diuretics. And then you want to be aware if the child has recently been on steroids or is on steroids chronically, and consider a bolus. Of course, most people give Decadron to kids for the nausea prevention. So pre-op fasting. So this is a picture of the inside of a minivan. And for those of you that have children, understand how easy it would be for your child to eat a decent amount of Cheerios on the way to the hospital the morning that they're supposed to be NPO. This cracks me up because, you take the car seats out and there's snacks all over your car. But an easy way to remember the NPO guidelines is 2468 water booby bottle cake. Okay. It rhymes, and I think it's a great way to keep it in your mind. Now, this year, the ASA came out with an update to the 2017 pre-op fasting guidelines. And there was a discussion about clear liquids up to 1 hour for children. The European guidelines and the Canadian guidelines changed to 1 hour, but the ASA says there's insufficient evidence to recommend it's safe for children to have clears up to 1 hour. So that's where we are with that. Now, once in a while, there are cases that are canceled because kids are get a hold of Cheerios on the way. I actually had a kid we had to wait on because he was 3 and drinking out of the toilet in the pre-op area. But those are few and far between. The majority of pre-op fasting issues are that children are left NPO for far too long. And this becomes significant because, they're hungry, they're thirsty, they can get hypoglycemic. A crabby child makes for a very crabby caregiver. And the longer they wait for surgery, the more the parents are just about to lose it. So it's just bad for everyone, especially diabetic children and then really small infants, like, under 30 days. As far as gum goes, in the updated guidelines, the ASA said there's no distinct benefit to chewing gum before surgery. There's not enough literature out there which supports that it's beneficial, but that if the patients come in chewing gum, don't cancel the case, just have them spit it out and proceed. Of course, if the kid swallows it when you say, "Are you chewing gum?" then you're going to have to delay or cancel the case. Murmurs. So this is always a hot topic of discussion. Systolic flow murmurs or Still's murmurs are common and in kids, and this is just due to turbulent blood flow in the ventricles. Still's murmurs are louder in high output stage such as fever and anemia, and they are actually louder when the kids are supine. So if you can't hear them when your preceptor tells you that the child has one in pre-op, odds are when the child's asleep and laying supine, you'll be able to hear the flow murmur. And then a quick tip for murmurs, pathological murmurs are diastolic. They are usually louder than grade 1 or 2. They affect the child's activities of daily living, and the child can have cyanosis. And pathological murmurs do not get quieter in the sitting or standing position. And what I tell students all the time is the only way you're going to get good at picking up murmurs is by wearing your stethoscope to pre-op and listening to the kids. So upper respiratory infections. These can cause peri-op respiratory complications for anywhere from 2 to 4 to 6 weeks, depending on which reference you look in. And most facilities have a designated policy for how to address upper respiratory tract infections. I mean, we know that kids get sick all the time. So, I think it's important when a child comes in for ear tubes that you actually do question the baseline of the child. Many kids are having ear tubes or adenoidectomies because they always sound and look sick. So you don't really want to cancel or delay an elective case because of an upper respiratory infection unless the child has fever, is excessively snotty, lethargic, grouchy, wheezing, has really bad bronchi, or at my facility, we cancel or delay for steroid prescription or antibiotic prescription suspicious of a lower respiratory tract infection. And if you have to do an urgent or emergent case, on a child with an upper respiratory tract infection, you just need to anticipate perioperative airway issues. So you just put your seatbelt on and you pray the ride isn't too bumpy. So pre-op anxiolysis. Some facilities pre-op everyone and other facilities don't pre-op. Some facilities give more than one agent. So it really just depends where you work. In the US, midazolam is the most common pre-op anxiolytic given to children. And the quick tip for this is that 0.75 milligrams per kilogram PO is a better dose for toddlers than the half per kilo. It just seems like toddlers need more midazolam. And the literature says that it takes 30 minutes to work. Most of the time, you can take the kid back to the OR after 15 minutes of oral Versed. And we mix oral Versed with PO acetaminophen also. And never trust a friendly toddler. Kids will be super friendly and playful as long as they can see their caregiver. But if you think, oh, I don't have to pre-op that kid, I've established a relationship, we've been playing in the pre-op area, and then the minute that you go to take the toddler away from the caregiver, it's a huge meltdown. So it's one of my rules, just never trust a friendly toddler. You can give Versed intranasally also, and there's a little flame on there because it burns like fire. So I don't do it unless I absolutely have to. The child will be extremely mad at you. And then you've created a super runny nose and a crying kid who now has all these secretions from the burning intranasal Versed. It does work really fast though. And of course you can give IV Versed for the older kids or the kids who are coming from the inpatient floor. And then dexmedetomidine, my life is better since dexmedetomidine and Sugamadex. That's what I always say, my anesthesia life. So you can give 1 to 3 mics per kilo intranasally of dexmedetomidine. And they say it takes an hour to work, but usually you can get a decently sedated kid in about 30 minutes. What you need to be aware of, though, is that like if you're just doing ear tubes, dexmedetomidine has that analgesic action also, and it'll be peaking about the time you get back to recovery room. So you may want to either do a little bit lower dose or just anticipate that the child is going to be sleepy in the PACU because it'll be peaking about the time you get in there. And then, of course, you can give it IV too, 0.5 to 1 per kilo over 15 to 30 minutes. So setting up your workspace, you guys know you need equipment appropriate for age, weight, and size. Most facilities have cheat sheets. We have a little manual that we can give the students. And then just remember that if the ET tube calculation is for uncuffed tubes, you need to downsize by 0.5 to 1 for a cuffed, appropriately sized cuff tube. I see students make this mistake a lot. So just remember, if you're using one of the uncuffed calculations, you need to downsize. And then just some quick tips. So once you know what the ET tube size is for your child, if you take 2 times that, you'll have the size of NG, OG, or Foley. 3 times that will be the depth of the ET tube at the incisor. And 4 times that is the max size chest tube for like a hemothorax. Once you see the kid in pre-op and you get an actual weight from the day, you want to finish up your weight-based drug calculations. And this is really important. You have to know the concentration of the drug. And by that, I mean, you're going to be drawing a lot of drugs up in TB syringes. So you need to know how many micrograms are in 0.1 cc. And why is this important? Because when you look at the medical errors with pediatrics, it has to do with a decimal point. So it's really important for you to be very confident when your preceptor asks you how much fentanyl is in 0.1 cc. You cannot be, making little mistakes like that. So just know the concentration of your drugs in small syringes. You want to draw up emergency meds for infants less than 1 year, critically ill children, or complex kids. And by complex, I mean syndromic, Downs syndrome, Treacher-Collins, Pierre-Robin. And why do I draw up drugs for kids less than a year? Because the quality data shows us that this age group is where you can get into really big trouble fast. So you don't have time to draw your drugs up when the kid's under 1. You can pass the same drugs, the clean drugs, through the day. So just, you just want to be aware that your preceptor may have a different opinion than I do about what age group to draw up emergency drugs. I don't always draw them up for healthy older kids. I just have them immediately available on my cart. And by emergency drugs, I mean atropine, propofol, Sux, and Epi. I don't give Sux for laryngospasm unless I absolutely have to. Propofol does a great job deepening the child. And, I always make an Epi stick, 10 mics per cc usually. And quick tips as far as weight-based drug calcs. Maximum dose of bupivacaine, 0.5% is 0.5 cc per kilo. And max dose bupivacaine, 0.25% is 1 cc per kilo. And then max dose of an LTA for kids, 1 cc of 4% lidocaine per 10 kilos of body weight is a quick way to calculate that. So induction. Inhalation or IV or combo, you just need to discuss it with your preceptor. By combo, I mean say you nitrous an older kid and start the IV and then do an IV induction. Either way, you want to have fun with kids. Remember growth and development. Learn the popular cartoons the kids are into. Learn some dad jokes. Kids love dad jokes. Sing songs. Sometimes we'll use iPhones or tablets for distractions if the kids are really into watching something. We flavor the masks on our circuits with lip smackers. If older kids usually will pick their flavor, and then I will just put a smell in there because I think it helps cover up the nasty odor of the sevoflurane. Sometimes we just talk about, how their dad's feet stink and they're going to start to smell stinky feet. But I do try to use the lip smackers when I can. Before induction, you want to have monitors on if possible. And I know that a lot of people don't wear precordials anymore, but as a student, they can really be a great learning tool for you. But if you don't use them in adults, it's going to be really hard to get adjusted to a precordial when you're taking care of kids. So I still recommend students use a precordial for taking care of kids. I still use mine. Nitrous, plus or minus with induction, it just depends on how you feel about it. It's bad for the environment. I never use it for small children under 1. I just induced with 100% SIVO. And then, there's a few different ways to do inhalational induction, slow titration versus 8% SIVO. So quick tips as far as positioning. Why is positioning important? So kids have big head, little body, right? Which leads to a natural neck flexion when they're supine. This increases their work of breathing. And it's not just babies, it's toddlers too. And you can see the pink arrow depicting the tongue base relaxing and falling against the posterior pharynx. This is a source of upper airway obstruction for kids as they're going to sleep. So the optimal sniffing position for an infant is where the nose and the chin are horizontally aligned. There's a wide anterior neck space, and the external auditory meatus and the sternal notch are horizontally aligned. Why is this important? Because it decreases the work of breathing for the child, and it aligns the oral, pharyngeal, and laryngeal axes for you. Okay, it makes mask ventilation easier for you, and it makes intubation easier for you. So you look like a rock star during induction. Now, what if you put a shoulder roll under an infant that's too large? Okay, this causes hyperextension, and it only moves the larynx more anterior, which makes sheer direct laryngoscopy even more difficult. So you can see here, the anterior neck space is wide open, but the external auditory meatus and the suprasternal notch are not in alignment, and the nose and the chin plane are not horizontal. So here's comparison of optimal sniffing position versus not optimal, okay? Here's optimal positioning for a toddler. You can just use a pillow if you want. We have those big pink donut pillows. And then for a child, okay? Try these in clinical. I'm telling you, if you're struggling with your intubations, this is going to make a world of difference for you. Okay, so some quick tips for masking. It's really important to size the mask correctly, okay? The cuff, the plastic cuff needs air in it or it will leak. Don't sabotage yourself. Put some air in that cuff. Place the mask on the glabella first, okay? Lay that part down and then fold down over the nose and the mouth, and the mask should not be occluding the nares. As far as masking one-handed, hand placement does matter. I know you guys know the C&E. This isn't the first time you've been masking. But what you need to realize with small children is if you grab too much of that submental tissue, you can actually cause upper airway obstruction. So you need to be aware when you are lifting the mandible to the mask that you need to try to stay on the mandible and off the soft tissue as much as possible. Now, the two-handed mask technique. This works great for upper airway obstruction like tonsillar hypertrophy. You can apply CPAP with your pop-off valve and then use both your hands to create jaw thrust. And I used arrows for the torque motion. So you're going to lift jaw thrust up and your thumbs are going to push down and really open that mouth. That's going to get you through stage 2 in a kid with huge kissing tonsils, because the last thing you want to do is put an oral airway in whenever a kid's in stage 2. So the stages of anesthesia. These are important for pediatric rotation because you actually see the children go through them. Stage 1 is induction. The child will go from conscious to drowsy decreased pain perception, amnesia, and nystagmus you'll see in the eyes first. Then stage 2, which I know you all know about, it's the excitation phase. This is where you have to be really careful because the child can breath hold, laryngospasm, have upper airway obstruction, and actually every child does partially laryngospasm with induction. Now, you can tell when stage 2 is coming in because their breathing changes and they get irregular respirations, the seesaw motion, and their heart rate goes up. Stage 3 is the surgical plane of anesthesia. This is where they lose their airway reflexes, their muscles relax, and then their heart rate comes down and they get more regular respirations. And there are 4 planes to stage 3. Those mostly have to do with their eyes and their pupils. Stage 4 is overdose. We want to stay away from stage 4, of course. It's severe depression of vasomotor and respiratory centers, followed by apnea and impending cardiovascular collapse. So quick tips for induction. You want to maintain CPAP at 10 to 15 centimeters of water through stage 2. You want to keep your right hand on the bag to monitor spontaneous respirations unless you need to do 2-hand mask technique. And one thing I'll stress to you is watch the child, not the monitor. You can feel upper airway obstruction through turbulence in the face mask. You can observe fog in the mask and intermittently kind of scan at the end-tidal CO2 waveform to check your seal. Again, try not to put an oral airway in stage 2. You want to listen to the pulse ox tone and heart rate. Watch the child's breathing pattern. Listen for laryngospasm with your precordial and adjust your mask technique and CPAP as needed. And then at the first sign of trouble, if you're not already at 100% FiO2, you want to go there. So you can assist the child's ventilations, but don't positive pressure ventilate until the IV gets started, unless the kid is apneic. Why? Because you don't want to deepen the child too much. If this happens and the child gets bradycardic, you're going to have to back off the SIBO until the IV's in. After the IV's in, you can positive pressure ventilate, turn the SIBO up, maybe give some propofol. We usually give some fentanyl if we're going to intubate. And most anesthesia providers don't give muscle relaxant before intubation unless the surgeon needs it for the case. Sometimes we'll put an LMA in before we start the IV. You guys know LMAs are sized by weight. You only want to attempt direct laryngoscopy and intubation when all the respiratory effort is absent. And if the child is light enough to breathe or make respiratory effort, you will probably trigger a laryngospasm with direct laryngoscopy. So just be patient, deepen the child with agent or give propofol. So just some quick tips for intubations. I find that a Miller 1 is usually too short for kids older, 3 or older. I love the Miller 1.5. It's a great blade, smaller than a 2, but longer than a 1. And it just really fits those kind of, 2.5, 3, 4-year-olds. You should use a Miller for kids 2 and under. Why? Because you don't want the first time you use a Miller blade to be in babies, right? You want to build some confidence with some older kids. And I included the ET tube calculations for kids greater than 2, or I find greater than 18 months. American kids are big. So most kids at 18 months can follow these calculations. Again, one's for cuffed, one's for uncuffed. There's several formulas. Just pick one and go with it. And then I included ET tube size by age and weight. I find most children 6 months or older are big enough for 3.5 cuffed endotracheal tube. Under 6 months, they're getting a 3 cuffed or a 3.5 uncuffed. And then for the tiny babies, we usually go by birth weight and gestational age for their tube size. Again, know your equipment. I showed some pictures of some cuffed endotracheal tubes and some an uncuffed endotracheal tube. You'll see the black line on number 1, which is the uncuffed tube, sits below the cords. And then for the cuffed tubes, one, the cuff is down, the other, the cuff is up, of course. Usually the glottic opening is between the 2 black lines. When you use the stylet to intubate a child, usually just a slight bend, like a hockey stick, is fine. It's all you need. There may even be too much bend on that endotracheal tube, but you get the idea. So Mack versus Miller technique. Again, use a Miller, make yourself use a Miller blade, make yourself practice. You guys know the Mack blade's curved. Again, scissor open the mouth for both. Enter the blade right side of the mouth, sweep the tongue to the left, advance the blade. The Macintosh goal is to be in the vallecula. The Miller blade is to lift the epiglottis, but you can use your Miller blade like a Mack blade, right? And then when you lift, you're reaching towards the opposite wall, okay? And then with the Miller blade, you're going to bury the blade, and we'll talk about that soon. So here's scissor open the mouth. No need to rock the head back. You're only going to make the larynx go more anterior and make it harder for yourself. You want to enter the right side of the mouth and sweep the tongue to the left. You can see there's a great picture of that angle there. And then you can see the direction to lift towards the wall. And then here's what I'm talking about by burying the blade. So why do you want to bury the blade? Okay, well, because if you bury the blade and you come out slowly, recognizing anatomy as you come out, it's much less damaging to the tissue than going in and tapping and looking, and then going deeper and lifting and looking, and then going deeper and lifting and looking. So just bury the blade and come out very slowly, okay? You should note the hand position that this provider is holding this blade. This is an excellent way to hold the blade. You don't need to grip the handle for a tiny child. You should never be lifting the head off the OR table. This leaves your right hand free for cricoid, and then you can instruct your assistant to help you with cricoid or to pull the cheek over so that you can get the endotracheal tube in. Now, if you look at the picture on the right, it's the incorrect technique. You can see how the right side of the tongue is sticking over on the side of the Miller blade. This is a mistake I see new intubators of children do. You have to sweep that tongue or you will not have enough room to get a small endotracheal tube through. And a lot of times what ends up happening is the blade ends up being stuck in the middle of the tongue, and the tongue looks like butt cheeks around the blade. You cannot get the endotracheal tube past the right butt cheek, so to speak, or the tongue on the right side. So this is very important. Please consciously think of sweeping the tongue. And here's your view, Mack blade, Miller blade. Again, you can always use the Miller like a Mack. If you have a view, shoot, right? Go for it. You want to be aware of how much time your direct laryngoscopy is taking. If it's taking a while, come out, ventilate, try again. Okay, we usually give our students 3 attempts at intubation before we take over. After intubation, you want to make sure you have a death grip on that ET tube, and while you attach it to the circuit. You want to remember to verify end-tidal CO2, bilateral breath sounds. And if you have your precordial on, you'll know right away you're in. You want to check for a leak by turning the pop-off valve to 20 and inflating the cuff to a proper leak of 15 to 25 centimeters of water, or you can use a manometer. So what you do is you apply 20 centimeters of water with the pop-off. You can hear the leak around the tube, and you inflate the cuff until the leak is gone at 20. Then you want to securely tape the endotracheal tube in, noting the exact depth at the gum, the incisor, at the lip, whatever, but just note exactly where it was, because 1 centimeter in or out in a 1200 grammer means extubation. Then you're ready for maintenance. With kids, halogenated agents, IV with analgesics and antiemetics. I don't usually give antiemetics to kids under 1 because their chemoreceptor trigger zone is too immature. I will give Decadron though. It helps with the airway swelling too. We do ERAS and opioid sparing, even opioid-free anesthesia for kids. Dexmedetomidine is a great adjunct to prevent emergence delirium. 0.5 to 1 per kilo prior to emergence is what I try to work in. On the shorter ENT cases, it's 0.5 per kilo. The longer cases, I try to get 1 mic per kilo in. You can do TIVA. For the preemies, we do opioid-heavy ketamine technique, low halogenated agent, because remember, they still have open shunts, and we don't want to tempt fate. Shunting is a whole nother lecture. And then fluid management, regional. If the case warrants regional, it's a great adjunct for post-op pain. And then in the US, the caudal block is the most common regional technique in infants. And by infants, I mean babies less than 1. And then emergence, deep versus awake extubation. This is an endless debate among pediatric anesthesia providers. It depends on who you talk to. I prefer deep extubation as long as it's not contraindicated. And by that, I mean difficult airway. But it depends on what your PACU coverage is like. If you work at a children's hospital where the PACU nurses are little airway nurses, then it's, you can deep extubate. Usually I deep extubate, but I don't leave the kids in PACU until they're through stage 2. So I'm really careful about not leaving them in stage 2. And of course, when I say deep, I mean you avoid stage 2. So you extubate in a surgical plane of anesthesia before the child gets to stage 2. And then if you're going to wake the child up, then you need to make for sure they have that good 11 grimace right between their forehead. That is a sign that they're extubatable and they are awake. Kids always wake up 3 times. I'm going to warn you, so don't pull the tube. You'll never regret leaving it in longer, but you will regret pulling it too soon. You want to have your emergency drugs and airway equipment ready for emergence. Sometimes I use an oral pharyngeal airway and sometimes I don't. It just depends how easy the kid was to mask down. Super easy, don't really need an oral pharyngeal airway. And then you want to suction the oral pharynx, extubate on 100% FiO2, and apply CPAP, 10 to 15 centimeters of water via mask to reestablish FRC, right? After extubation, we want to reestablish FRC and ensure open glottis. So a lot of times I see students, they're really nervous because the kid's not breathing after they extubated them. And, I'm kind of like, is the glottis, are they spasming? Well, how can you tell, right? Just give them a breath. and let yourself relax, that they're not in spasm. So if you apply positive pressure when you extubate, a lot of times the kids won't breathe for a little while. So if you're nervous, just try to positive pressure ventilate them. And then recovery position to PACU. So this is just a quick summary, kind of ways you can decrease your anxiety about peds and your peds rotation. Study, prepare, organize, assess, and debrief. Ask your preceptors for feedback daily. Establish goals for the day and seek out constructive criticism from them each day. Give yourself grace throughout your rotation and seek out every possible opportunity you can to get your hands on children. You'll only feel more comfortable by getting more experience. And then this is I actually got home from the National Scout Jamboree last night at 8 o'clock at night. It was in West Virginia this year. My husband and I took the Abraham Lincoln Council contingent of Scouts, because both of my boys are in Scouts and my husband is in Scouts. And they talked me into going to a 10-day camping trip. No hot water. But I put the picture up because the moral of the presentation pretty much is preparation can alleviate a lot of anxiety about taking care of kids. So by failing to prepare, you are preparing to fail, and Scouts are always prepared. So I just wanted to say thank you. I put my contact information up here. If you ever have any questions, don't hesitate to reach out to me.